Good morning, everyone, and welcome. Today, I am going to talk about a presentation that many of us see in the emergency department and also in the acute neurology ward. Yet, still, the struggle to classify cleanly the patient who arrives with acute persistent vertigo, dizziness, or imbalance and has no nystagmus. For more than 3 decades, the classical acute vestibular syndrome, abbreviated as AVS, was defined by the presence of spontaneous or gaze-evoked nystagmus. That definition underpinned the validation of the hints and hints plus, which remain highly accurate tools, but only when nystagmus is present. In the year 2018, the ICD-11 quietly changed the landscape. The nystagmus is no longer mandatory. Suddenly, a large and clinically important subgroup was formally brought under the AVS umbrella. We now call this subgroup the Acute Imbalance Syndrome or AIS. Why does this matter? Because nearly half of all central AVS cases, almost 50% of the strokes that present with acute vestibular symptoms, present without nystagmus. The vascular territory makes a clear difference. Anterior inferior cerebellar artery lesions almost always produce nystagmus, while the superior cerebellar artery and posterior cerebral artery lesions far often produce pure imbalance. At the same time, the non-central causes of acute imbalance syndrome are completely different from the classic peripheral vestibulopathies we used to think about. That is the dysautonomia. Medication effects, cardiac and metabolic diseases dominate in the group. The practical consequence is straightforward. The bedside algorithms we trust in classical AVS with nystagmus are not validated and can actively mislead when nystagmus is absent. We therefore need a different diagnostic approach, one that privileges gait and truncal assessment, that is, the standing and graded truncal stability, and a structured search for the systemic causes. Over the next few slides, we will unpack the epidemiology from a recent systemic review and meta-analysis of more than 11,000 patients, look at the pathophysiological spread between the vestibular and postural networks, and finish with a practical bedside pathway you can take back to the emergency department tomorrow. Thank you for joining. Let's begin. So, this is my title slide, evidence based neurology briefing about the acute imbalance syndrome. Vertigo, dizziness, or imbalance without nystagmus, refining the acute vestibular syndrome. We will include the ICD 11 definition, elaboration, etiology, standing protocol, and bedside management. And this is based on the article by the Skims, Karski, and other colleagues, the epidemiology and clinical presentation of the acute imbalance syndrome, AIS, a systemic review and meta-analysis published in the European Journal of Neurology in 2026. The paradigm shift, nystagmus no necessary, that is no longer mandatory. In 1988, the Hoston and Barlow, they defined classical acute vestibular syndrome, acute rapid unilateral vestibular tone imbalance, peripheral or central vestibular lesion. Spontaneous or gaze-evoked nystagmus was required to define the acute vestibular syndrome. The hints examination, which was a bedside test battery, is validated only here. The sensitivity reaches around 95% and the specificity is 92.6%, and it is only when the nystagmus is present. ICD 11 in year 2018, the nystagmus became non-mandatory. AVS definition broadened beyond the acute unilateral lesions, captures non-vestibular or postural network causes. AVS now includes patients without nystagmus. This subgroup is equivalent to acute imbalance syndrome or AIS. So the consequence, bedside algorithms built for classic AVS, that is the hints or hints plus, are not validated and may mislead in patients without nystagmus. What is acute imbalance syndrome? This is all AVS cases around 2730 pooled meta-analysis about acute imbalance syndrome, acute onset persistent vertigo, dizziness, and obligor imbalance without nystagmus, a distinct subtype of AVS as currently defined by ICD 11-2018. Diagnostic criteria applied in this review are acute onset persistent symptoms, not episodic or positional. Stance obliques gait imbalance and obligor vertigo or dizziness. Absence of spontaneous or gaze-evoked nystagmus. Presence of positional nystagmus is still present. That is usually implies a peripheral BPPV but not acute imbalance syndrome. Also known as acute truncal ataxia, terminology from the review's umbrella definition. Imbalance is equal to unsteadiness, disequilibrium, truncal or gait ataxia. This is about the Barony Society's postural symptoms defined long back. So, in this pooled analysis of around 2730 patients, the acute imbalance syndrome, that is without nystagmus, constituted 47.3%, and the acute vestibular syndrome with nystagmus constituted around 52.7%. So, nearly half of all acute vestibular syndrome presentations lack nystagmus entirely as per this pooled analysis. So AIS is common and frequently central. 47.3 of all acute vestibular syndromes cause cases present without nystagmus. 49.1% of AVS with central cause presents as AIS. 22.8% of AVS with non-central cause presents as AIS. 30.7% of all acutely dizzy emergency department patients met the AIS criteria. This is, however, a single study. So, these are the fraction of central AVS presenting as AIS by the vascular territory. As we can see that the largest territory is the PCA 62, the superior cerebellar territory 57, then the PICA 40, and AICA represents only 9% because most of the cases of AICA strokes, territory strokes, have nystagmus. So the reading pattern is that AICA oblique medial PICA is affecting the vestibular network and it is usually with nystagmus. The SCA oblique PCA, that is involving the vermis, midbrain, and thalamus, involves the postural network, and this causes acute imbalance syndrome without nystagmus. There are two networks and two presentations. Vestibular network AICA or medial PICA territory, vestibular nuclei and root entry zone where the root enters the brainstem is affected. Asymmetric vestibulo-ocular reflex signals results in spontaneous nystagmus. Classical AVS with nystagmus results. AICA strokes AIS occurs only in 9% cases. That is, acute imbalance syndrome without nystagmus occurs only in 9% of the cases. And as compared to the postural or non-vestibular network, this usually involves the superior cerebellar territory or the posterior cerebral artery territory. Superior cerebellar vermis, midbrain, and thalamus are involved. Postural or truncal control affected, the vestibulo-ocular reflex remains intact. Imbalance oblique ataxia occurs without nystagmus. Superior cerebellar artery strokes, AIS occurs in 57%. In the posterior cerebral artery strokes, the acute imbalance syndrome occurs in 62%. So, for PICA strokes, the lateral branch lesion rarely show nystagmus. The medial branch lesions do. Branch matters as much as the territory. So, more than 90% of central AIS cases are linked to ischemic stroke. Therefore, a stroke workup is at least as necessary as in AIS as in AVS with nystagmus. The risk rises further with the ABCD score of 4 or more. So, as we see, Ischemic stroke, all territories 48.8% presented with acute imbalance syndrome. Posterior cerebral artery 61.9% presented with acute imbalance syndrome. Superior cerebral artery strokes around 56.5% presented as acute imbalance syndrome. Traumatic brain injury 100% they present with acute imbalance syndrome. Persistent postural perceptual dizziness, the triple PD, present with 87.5%, they present with acute imbalance syndrome. The tumor 78.6%, vestibular migraine only 9.1% present as acute imbalance syndrome, and in Wernicke encephalopathy 0% were found to have acute imbalance syndrome. So the non-central AIS has a distinct differential based on this graph. Peripheral vestibular disorders, acute unilateral vestibulopathy, and labyrinthitis present with nystagmus in 97.3% of the time, virtually never AIS. Medical systemic causes, dysautonomia, drug oblique medication, side effects, cardiac disease, and metabolic derangements dominate the non-central AIS differential, the opposite pattern. So the takeaway is that absence of nystagmus essentially excludes acute unilateral vestibulopathy by definition, which was formerly called vestibular neuritis, but does not exclude a systemic medical cause. Non-central acute imbalance syndrome workup should prioritize orthostatic vitals, cardiac rhythms, including the Holter monitoring, medication review, and metabolic history. So why Hens fails without nystagmus? The Hens and Hens plus validated in acute vestibular syndrome with nystagmus. It has a sensitivity of 95.3% and a specificity of 92.6%. Hence, applied to acute imbalance syndrome, a single center cohort with no nystagmus, it found that it was 66.7% diagnostic accuracy was there and the specificity was not validated. The root cause of failure is that Hens relies on the science of asymmetric vestibular input, that is the VOR asymmetry, skew deviation, the features that require active unilateral vestibular tone imbalance. Non-vestibular postural networks of systemic causes have symmetric normal head impulse test and no skew, defaulting hence logic to central regardless of true cause. Nystagmus intensity can also fade within first 24 hours after a stroke. And AVS with nystagmus presentation can shift into acute imbalance syndrome presentation depending on the examination timing. So the standing algorithm, which is shown here, a four-step bedside protocol validated for differentiating central from peripheral acute vertigo, including patients without nystagmus. So number one is the spontaneous nystagmus. Look for the spontaneous or gaze-evoked nystagmus at first. Make it sure when you see a gaze-evoked nystagmus, you don't carry the target to be followed away very far. Only 20 to 30 degrees is required. Otherwise, you will in fact make a wrong diagnosis of making a endpoint nystagmus and defining it as the gaze evoked nystagmus. Second is the direction of the nystagmus. If nystagmus is present, characterize its direction whether it is horizontal, torsional, or vertical. A pure horizontal nystagmus is almost never a central. However, a pure vertical and a pure torsional nystagmus is almost exclusively a central nystagmus. The third is positional nystagmus. Is no spontaneous nystagmus is elicited or seen. Test for positional test by the Dix-Hallpike test or supine rule test. And if you get a nystagmus, it is likely to be BPPV. But there is a rider here that it should be responsive to the repositioning maneuver. If it does not respond, the central cause, including acute insults in the velocity storage mechanisms, may be there, like the stroke in posterior circulation involving the nodulus and uvula, and sometimes in the vestibular migraine also. The fourth is the gait assessment. If no nystagmus at all, the AIS pathway, that is acute imbalance pathway, assess the severity of the gait or truncal imbalance. The worrisome result is that a patient with no spontaneous positional or gaze-evoked nystagmus and significant gait or truncal imbalance has no clear peripheral explanation. Treat as high risk for central stroke cause and proceed to neuroimaging. There is again a rider here. A patient with dissociative illness may come with the truncal instability or gait imbalance, and in that case, your experienced eyes need to discern that this is a dissociative gait and not a true truncal imbalance. So, this is the protocol which is followed by the Italian emergency department physicians. Acute vertigo or unsteadiness or imbalance coming to the emergency department, they look for the nystagmus by Frenzel glasses. If nystagmus is spontaneous and if it is pluridirectional or vertical, it is central vertigo. If it is unidirectional, they do a head impulse test. If it is negative, it is central. If it is positive, it is acute unilateral peripheral vestibulopathy. But if a patient with AUVP is unable to walk without support, it is a central vertigo. If nystagmus is absent, but the patient is unable to walk unsupported, and it is ensured that it is not a dissociative illness, then it is a central vertigo. Third is if positional nystagmus is evoked by supine roll test or Dix-Hallpike test, it is BPPV provided that the patient is able to walk unsupported and he responds to the repositioning maneuver. Otherwise, it could be a central positional nystagmus due to acute infarct in the velocity storage mechanisms or even in the cases of vestibular migraine. So the graded gait and truncal stability GTI scale is very important. There are four grades: 0, 1, 2, and 3. 0 is normal gait, able to walk normally and maintain tandem stance, that is eye open, for more than 3 or more seconds. The interpretation is that there is no significant gait instability. GTI grade 1 means mild to moderate imbalance, walks independently but cannot perform the tandem instance, eyes open for more than 3 seconds. This is called mild truncal oblique gait impairment. Grade 2 is severe imbalance, cannot walk independently and requires support, or cannot stand in rhombus position with eyes open for 3 seconds, and this is graded as moderate to severe truncal ataxia. The grade 3 GTI is unable to stand upright without assistance or unable to even sit unsupported, and this is regarded as severe truncal ataxia, strongly suggestive of a central region. So the grade 0 to 1 is more commonly seen in peripheral vestibular disorders like acute unilateral vestibulopathies, although grade 1 can also occur in small cerebellar infarcts. Grade 2 or 3 substantially increases the likelihood of central cause, particularly the cerebellar stroke. A meta-analysis found that using GTI of 2 or more as cutoff provides the best balance of sensitivity, which is around 70%, and specificity around 83% for central AVS. GTI grade 3 has a very high specificity of around 99% for central lesion, but relatively low sensitivity, so its absence does not exclude this stroke. So standing protocol is validated performance 84 to 100% sensitivity for the central causes across the emergency department validation studies, 87 to 94% specificity for central causes across the ED validation studies. It reduces the unnecessary neuroimaging referrals, reduces the unnecessary hospital admissions. So the GTI grading sensitivity and specificity, grade 3 alone, inability to stand or sit unassisted. The sensitivity is relatively low, 44%, but the specificity is very high, 99.1%. Grade 2 or more, inability to walk independently, or grade 3. The sensitivity is 70.8% and the specificity is 82.7%. So, a grade 2 or more is a better indicator in terms of sensitivity and specificity compared to grade 3 alone. GTI is a valuable addition to standing oblique hints plus don't apply. That is, the GTI is a valuable addition where the standing protocol or hints don't apply but does not alone reach the hints plus level accuracy combined with the clinical risk factors. Bedside approach to patients with suspected acute imbalance syndrome. Confirm the syndrome. Acute onset persistent more than 24 hours, vertigo, dizziness, or imbalance. No spontaneous or gaze-evoked or positional nystagmus on examination. Assess the vascular risk factors: age, hypertension, dyslipidemia, atrial fibrillation, prior stroke, or TIA. Consider ABCD score. 4 or more raises the stroke risk, that is a settled cause risk. Grade, gait, and truncal stability. Apply standing gait, step, and oblique or GTI rating. Grade 2 or more GTI or an inability to stand or walk unassisted is worrisome. Route by the risk: high risk oblique worrisome, urgent MRI diffusion weighted, repeat if initially negative. The low risk is screen for the non-central causes below. Screen non-central causes, that is the orthostatic vitals, that is the blood standing and blood pressure and pulse in standing and supine positions, ECG and rhythm monitoring by Holter monitoring, medication review like the sedatives, anti-epileptic drugs, particularly the diphenyl hydrogen sodium and carbamazepine, and sometimes also the pregabalin. Metabolic panel including the hyponatremia and hypomagnesemia infection screen. And lastly, reassess within the 24 hours. Ocular motor vestibular findings evolve. Nystagmus may resolve, converting AVS to acute imbalance syndrome. Early less than 24 hours examination is the most reliable. So, management, there are two distinct pathways. Central suspected stroke, around 49% of sectoral AVS, admit for observation in the stroke unit as per the local protocol. MRI diffusion weighted, which may be repeated at 24 to 72 hours if initial scan is negative. Evaluate thrombolysis eligibility as per the standard mild stroke pathways. Full vascular risk factors workup, including the echocardiography, rhythm monitoring, carotid or vertebral imaging as indicated. Secondary prevention with antiplatelets or anticoagulation, statins, risk factor control. Neurology follow-up for residual imbalance or rehabilitation. Non-central causes or systemic, around 23% of the non-central AVS. Orthostatic vitals like lying and standing BP and pulse. Dysautonomia is the leading identified cause, especially the diabetic dysautonomia. Medication, reconciliation, sedatives, antihypertensive, antiepileptics, particularly the phenytoin sodium, carbamazepine, and the drugs commonly used in orthopedics as in neurology like pregabalin. ECG and cardiac workup if arrhythmia or heart disease is suspected. Metabolic panel, glucose, electrolytes, thyroid as indicated. Treat or adjust the underlying systemic driver. Vestibular causes are rare here. Safety net advice is a follow-up, re-examine if symptoms evolve. So acute imbalance syndrome, in summary, the key takeaways are: AIS is equal to AVS without nystagmus, now formally captured by the ICD-11 definition of AVS. Almost all central AVS cases, 49.4%, present as acute imbalance syndrome. It is common, not rare. Superior cerebral artery and posterior cerebral artery strokes favor AIS. Anterior inferior cerebral artery and posterior inferior cerebral artery strokes favor nystagmus. The territory predicts the presentation. The medial territory of the artery, it presents with AVS with nystagmus, while the lateral territory may present with AIS, that is acute imbalance syndrome without nystagmus. Hence, plus is unvalidated and unreliable without nystagmus. Do not rely on it in the acute imbalance syndrome. Standing with a sensitivity of 84 to 100% and a specificity of 87 to 94%, and the graded truncal instability are the appropriate bedside tools. Non-central AIS has distinct differential dysautonomia. Medications like phenytoin, sodium, carbamazepine, pregabalin, gabapentin, cardiac and metabolic disease. The metabolic disease is the basically hyponatremia, hypomagnesemia, and it is not peripheral vestibulopathy. Finally, early less than 24-hour assessment matters. Nystagmus can fade over time, shifting AVS into AIS presentation. So, this finishes my presentation on acute imbalance syndrome based on the recent publication by the Skemts, Zavargal, Diago Kaski, and Tarmutzer in the European Journal of Neurology published in 2026. Thank you very much.